Hi, I'm Peter Cox. I'm one of the physiotherapists on the adult amputee rehab program at Parkwood Hospital, and we're going to put together a videotape for teaching purposes to talk about how to go about tensoring a below-knee amputation. And before I show how you do that, just a couple things about tensoring. We do that as soon as it's medically correct to do it and as comfortable for the patient, and we want to teach the patient how to do it themselves because they need to do it when they come into the program. And you want to do it for a couple reasons. One is to help reduce the swelling that comes with amputation, and the second is to try and shape the limb. So there's a couple, shape the limb to allow it to fit into a prosthesis. So there's a couple features that you need to be aware of when you're shaping. Most of the pressure needs to be directed to the sides of the fleshy part of the limb here to try and bring those in and prevent the formation of what we call dog ears. You also have to be aware of where the bony structures are. So you don't want to have a lot of the tension over the ends of the cut bone. So at the end of the tibia here, which is cut, on the knob sort of up where the patellar tendon attaches, called the tibial tuberosity, which can be a little prominent and can provide an area of friction. And also on the side of the limb where the head of the fibula bone is. That's also a bony spot that shouldn't have a lot of tension on it, which would cause some friction and breakdown of skin. A lot of our patients are diabetic, and for that reason it's important that the skin is taken care of and isn't under a lot of stress. Now, you may have seen other examples of tensoring that begin sort of along the front of the limb like this, and we have gone away from doing that in our program, and we would advise against that for the simple reason that it tends to first direct the fluid to those sides, which you want to avoid. So we always tend to start on the diagonal. I'll go through that in a minute. As far as tension goes, we don't worry too much about putting more tension at the bottom and less tension at the top. What I try to do is I use the same tension from the bottom and the same tension at the top, but what I try and do is put more layers down here in this area and fewer layers as you go up. And as you add the layers, each layer contributes some tension. So I'm kind of looking for about 1/2 to 3/4 of the full length of the stretch. So if this is 0 and this is fully out, no more stretch, sort of in the 1/2 to 3/4 of that range is the amount of tension we need to put on. So when we start, again, we don't start in the middle, we're starting on a diagonal, and one little thing that patients should try and get used to doing is putting the limb, or putting the roll so that it is faced away from their body, and they're rolling it towards them as they place it against their body. A lot of people will start the other way. They'll have it like this, and they'll be unrolling the roll, trying to place it against the limb, which often ends up with them letting go and the roll going across the floor. So that little change makes a huge difference in how you can control the roll. Okay, so again, it doesn't matter whether you start this direction or this direction. You start on the diagonal, and the first layer is fairly light on there, and what you want to do on the first layer is just get it around the two corners using your hands and getting it anchored on the front here with enough tension so that you don't have it bulging up at the edges of the tensor here. So that's good tension there if it just sort of snaps back and it's flat. Once you've got it anchored, your second hand is available to place it where you need to place it, and then you want to start doing your diagonals across the bottom here to fill in all of the skin space here so there's no skin showing. And if the limb is fairly short, the best way to cover the very middle is to take a nice long diagonal up above the knee, because that way you can come down. I'm using my free hand to place that, and you can come down and very easily cover any of the skin space that's showing on those long diagonals. Okay? Once you've got them covered, then you can focus a little bit more, getting all the layers down the bottom here first, placing it with the other hand if you need to. Once you've got 3 or 4 layers down the bottom, you've got the tension that you need to create the gradient, then you can start bringing the tensor a little bit further up the leg with fewer layers as you go up, keeping the diagonal. You can see the patient is keeping the knee nice and straight. I'm going to crisscross above the knee, another area to watch out for a lot of tension. And you want to end up above the knee, so you need a long enough piece of tensor without wrinkles forming in the back, so make sure you get them smoothly out and bring it around to finish. And if you're lucky, you finish right on top. Okay? The last thing to remember is that when you are attaching this, we don't use pins. We go away from using pins or those clips. We use tape and tape that down, especially in the diabetics, because we don't want to have the pin pricking the skin, etc. So that's how you'd like to finish up. Above the knee, knees in a straight position, should be kept straight. And when the patient is advised to do their exercises, you advise them to take this off to do the bending and straightening exercises, because even with a good wrap job, if they do the exercises and they're bending and straightening the knee, the friction under there could cause the skin to break down, so you want to avoid that. So this should be on at all times, except when they're bathing, washing the limb, giving it a short break every 2 to 3 or 4 hours from the compression, or when they're doing their exercises.
You did a fine job, Peter.